One of the most amazing activities we can do as human beings is walking. My name is Marcel Grzebellus. I'm IPNFA senior instructor from Germany, and my topic today will be about gait. Gait is the natural way of locomotion for human beings. So it's something which is happening almost automatic. I have to initiate the gait pattern, have the intention to go from one place to another. But once I started to move, my feet are walking by themselves. Gait is part of our genetic program. So the software to run the gait pattern is already installed on the hard disk, which is our central nervous system. At the age of 12 to 14 months, every healthy child will start to walk. And of course, it will not be a refined movement, but with many repetitions and of course, many falls, it will become a smooth pattern of locomotion. Being able to walk means independence. So participation is gaining with the ability of gait. As gait is such a high-level motor performance, of course it's very prone to little changes in the body. So impairments on body structure or body function level will easily show in the gait pattern. So in therapy it's very useful to have applications to improve the gait in respect of safety, but also economy and speed. In PNF, gait class is part of our courses. So we have a couple of applications to improve the gait. In my presentation, I will explain the basic features of gait and then show the basic gait class of PNF. I have also some patients to show how we apply these tools of PNF on a real situation. So please follow me and enjoy.
What are the features of human gait? Human gait is characterized by a bipedal way of locomotion. This feature we share with a couple of animals as kangaroos or birds who are bigger and spend much time on the ground like chickens.
Dino!
And dinosaurs, of course. The legs move in a reciprocal way, which produces a changing base of support and switching between 2 feet and 1 foot ground contact. In contrast to running, there is a permanent floor contact in gait, so the kangaroo is definitely out here. Taking a closer look at this feature, we find that this changing base of support is characterized by short double limb stances and long single limb stances. The ratio between these two is 1:3. The next specific feature is the reciprocal arm swing. At least this feature distinguishes human beings from chickens.
Dino!
Of course, the dinosaur will stay here, yeah. Honestly speaking, I cannot imagine an arm swing with this guy here. The arm swing is reciprocal to the leg movements. In combination with an upright trunk, this impact of the extremity movements result in a rotational challenge for the trunk. Besides these basic features, the gait style will be different from person to person. As every activity, the performance depends a lot on the individual situation, so what kinds of proportions are there, which kind of resources are available, what are the properties of the body structures. And then on the environmental side, it makes a big difference if you're walking on flat surface, uneven or even soft ground. Also, if you have a good grip with your shoes, or if you're walking on slippery surface like ice. During lifetime, we are actually changing our personal style of walking. So as a kid, of course, we walk in a different way than as an adult or elderly person. Some figures about normal gait. In normal gait, the cadence is 100 to 120 steps per minute. The stride length, which is left and right step together, is about 1 meter 40, and the average speed about 4.8 kilometers per hour. What has to be accomplished during a gait cycle? Perry identified 3 major tasks which have to be managed. It's weight acceptance, single limb support, and limb advancement. Weight acceptance is a double limb stance situation. Here, the transfer of the body weight from the rear leg to the front leg has to be accomplished. The according phases are initial contact and loading response. Single limb support comprises the 2 phases of mid stance and terminal stance. The task is to transport the center of body mass over 1 foot forward and in terminal stance even beyond the base of support. The task of limb advancement starts in the second double limb stance, which is pre-swing and is accomplished during initial swing, mid-swing and terminal swing. From these 3 tasks, probably single limb support is the most challenging for patients with gait problems. When we take a look at the normal gait cycle, we can see that the double limb stance in comparison to the single limb stance is pretty short. Or in other words, single limb stance takes a long time, and this is really a challenge for patients with weight-bearing problems. A patient who is slowed down or who has balance issues shows a double limb stance which is prolonged and a shortened single limb stance. A unilateral involved patient, like this patient here with a femur fracture, shows typically a short stance on the affected side. What are the requirements for normal gait? In order to walk, we need a motor. So this is our musculoskeletal system. We need a central control system which is steering this motor. We need energy supply and we need a psycho-emotional support. The execution of the locomotion is realized by the musculoskeletal system. The system must provide an adequate passive mobility, but also muscles and fascias need to be ready to produce the necessary force. In order to make the movement smooth, an adapted tone is required. Also, it's necessary to provide the necessary stability in respect of function and in respect of the postural control. The impulses for bringing the muscles into action are coming from the neuronal control system. The hardware is the central and peripheral nervous system. The software for the locomotion is using different parts of the CNS. In the spinal cord, central pattern generators are producing the basic locomotion drive. These areas are the brainstem, cerebellum, motor cortex, and subthalamic regions, where volitional and automated impulses are generated and adapted to the specific needs. In order to generate an adequate and functional output, sensory information is required. Vestibular, visual, and the somatosensoric stimuli are essential to give the CNS an orientation what to do, how to react, and how to plan movements. Also, auditory stimuli are supporting the perception of the environment and can facilitate the locomotion, for example, by rhythmic cues as music. The undisturbed interaction of the different parts is a requirement for an optimal output. As we know from daily life, without energy there is not much possible. Here, the respiratory and cardiovascular system make sure that the CNS and the muscles stay powered. In respect of Gait, the affective setting should not be underestimated. Motivation and self-confidence are really important aspects for many patients. Of course, the absence of pain will have a big influence on the gait pattern. During the activity of Gait, these four systems will be permanently active. Changes in one system will immediately cause adaptations in the other systems. Gait class in PNF. The priority target of the Gait class is the independence and safety of the patient. Here, an achievement of the maximal normal function and the reduction of compensation to the necessary should act as a guideline. Very often, the therapist must find a balance between the aspect of walking economy and an avoidance or reduction of unphysiological stress on body structures. In the following, I will demonstrate the basic PNF Gait class applications on an example of a hemiplegic patient. In the first step, the impaired gait functions must be identified in order to apply a targeted treatment. Our patient here is able to walk short distances by himself, also without shoes. Normally, he is using a walking stick. But he can also walk without one. To keep it short, I will focus now only on one main issue of his gait style, and that is the shortened single limb stance. As we can see, the initial contact is happening with the forefoot, and the knee stays locked in hyperextension throughout the complete single limb stance. The hip is not extending, and the trunk is leaning forward during stance on the right. In a second step, we need to find the underlying impairments for the gait deviations on body function and body structure level. It is necessary to understand how these impairments are related to each other. The checklist here can help to structure the results of the assessment in order to find a logical hypothesis for the gait deviations of the patient. So we can relate body functions here to the different systems which are necessary for walking. First, we quickly check off all functions which are not impaired. In this case, there is no pain, no cardiovascular or respiratory issue. On a closer look on the gait pattern, we can observe that the ankle is hardly moving and the tibia does not move forward during stance. So we need to check first if there is any range available in the ankle joint. A passive movement to neutral with or without gastrocnemius is possible, but there is a lot of resistance at the end of the movement. A fast elongation of the triceps elicits a clony at about 15 degrees of plantar flexion with both variations. This proves the presence of spasticity. So going back to our checklist, here we can state the passive dorsal extension is possible to neutral. Then we have the tone issue, which is of course not only comprising the plantar flexors. In order not to get lost in details, I quickly summarize the further impairments. weakness, especially in the lower extremities of the right side, a lack of selective motions, proprioceptive and tactile deficits distally on the right leg, and an unsafe feeling during gait. All these different impairments will have an impact on the balance during gait, especially single limb support on the right side. So let's start with the gait class now. In most cases, gait class will start in the wheelchair, at or on the treatment table, or on the mats. The purpose is to prepare the gait activity by focusing first on impaired body functions. In the treatment progression, these body functions will be integrated in treatment applications which are close or actually on activity level. Once the patient is in standing position, we should try first to establish an optimal alignment of head, trunk and lower extremities. This will stimulate the postural control system and allow different muscles to work in a functional way. With neurologic patients, it usually has a good impact on the tone situation. The PNF tools we are using are approximation and the technique of stabilizing reversals. In order not to be disturbed by balance reactions, we create a safe environment for the patient. That can be standing in front of a treatment table or in parallel bars. The patient is allowed to hold on so he can focus on the body alignment and on single functions, which we will stimulate in the following. A bilateral grip on the anterior part of the pelvis can provide some stability for the patient, but it can be also used for applying resistance or approximation. Approximation should target to the middle of the foot. As a preparatory exercise, stretching of the gastroc makes sense. One possibility is a prolonged elongation of the calf muscle. After working on the alignment and balance in standing, the next step will be an increased weight bearing of the affected side. This weight shifting we can facilitate from the pelvis with a small resistance. The center of body mass is moved from the non-affected side to the middle and gradually onto the affected side. The resistance on the pelvis for the weight shift should be small and guiding. Once the body weight is on the affected side, we can approximate with more power. Side steps with resistance from the left side of the pelvis will increase the weight bearing on the right foot and the abductor activity on the right side. The same should be performed with an unlocked knee. A tactile stimulus on the knee with a small resistance will tell the patient where to keep the knee. And now, in the following, the patient controls the knee by himself. Weight shifting in a slight stride position will be the next. The task of weight acceptance is being trained here by moving the center of body mass from the rear leg to the affected front leg. Taking a step with the opposite leg will be training the single limb support. Again, we should take care about the controlled knee position. Walking with a guiding resistance will combine the steps left and right and facilitate a walking rhythm. Here we can compare the pre- and post-treatment situation. The tibia moves forward and the step with the left foot is bigger. The patient I like to introduce here is Dennis. He's 32 years old. His diagnosis is a polytrauma, including a traumatic brain injury and an incomplete spinal cord injury on the level of T4-5, which is ASIA-C. He had multiple fractures of the upper extremities and his accident is 8 years ago. He's using a wheeled walker, or he can also use walking sticks, depending on the day and depending on the environment. When he's coming from sitting, he has some trouble getting into upright standing. We can see here he's fighting with gravity in order to get into alignment and to extend the hip. He does not use ankle strategy. He can walk in parallel bars without holding on. But he does not dare to try this style of walking outside the parallel bars. His wish is to gain more safety in gait, so to be able to walk in open space for a short distance. His trunk here in the lateral lean test, leaning to the right side, looks pretty good. Leaning to the left side, we can see a difference. This is not that far. He is complaining about a tightness of the right side of the trunk, very often in his abdominals and in the quadratus, but also he does not feel strong on the right side. Here we see the difference between left side and right side, lean. Which are the underlying impairments for his gait limitation? First, we check off the non-affected body functions. Cardiovascular and respiratory functions are fine. Sensory is okay and there is no pain. The most obvious impairment is the balance in standing and walking. He does not use any ankle strategy, which can be explained by the weakness of the leg muscles. This weakness also results in coordinative alterations. There is a tone issue on the right side of the trunk and also in the lower extremities. But also we find a tightness of the iliopsoas and of the trunk on the right side. So side bending is impaired and extension of the hip is reduced. Insecurity in open space in the sense of fear of falling is a big issue for him. In the following, I will demonstrate a few preparatory exercises focusing on the trunk, especially here the elongation and stimulation of the right side. These kind of exercises have a good effect on the tone situation of the patient and the control of the spasticity of both legs. I'm using a flexion abduction external rotation pattern with a technique of dynamic reversal combined with an upper trunk rotation. Combination of scapular posterior depression with anterior elevation of the pelvis on the right side with a technique of combination of isotonics will stimulate the control of the right trunk. Lower trunk rotation, here the knees are starting on the left side and the patient has to pull back to the middle. Again, right side trunk is the focus. This exercise is also good for the abdominals. Full lower trunk rotation, here with the technique of dynamic reversal, has a good effect on the tone situation and is stimulating the trunk in an equal way. Posterior elevation of the pelvis with lifting of the knee stimulates also the gluteus maximus upper part, which is important for walking. In sitting, I'm working here on alignment and on an upright position with combination of isotonics, approximation in the desired position, plus stabilizing reversal to stimulate the trunk ventral and dorsally. Weight shifting to the right side, lifting the left side of the pelvis, is intending to elongate the trunk. We can see he has some difficulties to do that. We'll see that in the opposite side. Here he can elongate the left side much better, or shorten the right side much better. In a higher sitting position, we get more input to the legs. I'm using here the trunk extension pattern with eccentric work, static and concentric. Via irradiation we can reach also the lower extremities in this way. Same to the opposite side then. In standing in parallel bars, alignment first. I'm using the grip on the pelvis for getting the pelvis in between shoulder and feet in a good position. Continuing with a stabilizing reversal. In the next, I'm asking the patient to let go from the parallel bars, so he's standing freely and has to respond to my changing resistances. In between, a hands-off exercise here in the sense of mobility on top of stability, so to incorporate some trunk rotation while he is balancing on his feet. So 1 foot on a stepper will stimulate more weight bearing on the rear leg. We can use the leaning forward to stretch the iliopsoas and the triceps of the rear leg. Or we can use in the same position anti-elevation of the left side of the pelvis in order to stimulate the abductors on the right stance leg. Stepping up is a functional exercise in the same sense. Stride position. So here weight shifting to the front leg is the topic. I show him the position, make him hold, and ask him to come back. So that would be like a combination of isotonics. But once he felt the end position, I ask him to repeat it by himself. I give him some tactile stimuli and resistance in order to correct the final position in the sense of replication, and he should repeat and copy the position by himself. Taking a step to increase the weight bearing on the left side, we can see stepping backwards is, like with many neuro patients, a problem, so it makes more sense, instead of stepping forward and backwards, just to continue step left and step right side in a sequence. So walking inside parallel bars, then outside for longer distance and for more speed. And here, free walking in a safe environment. And we can see now when he's walking back, as soon as he is speeding up, his stability is becoming better, so probably the pattern generators are being started. In direct comparison, the pre- and post-treatment situation. The next patient I like to introduce is Alex. He is 63 years old. His diagnosis is a polytrauma, including a traumatic brain injury, and he had multiple fractures. The situation is 9 months post-accident. His wish is to become more independent and safe in walking, especially outside the house. We can see he can stand up by himself, he can put back his walking stick, he can walk without any aid, he uses a wide base of support, and he can also turn in standing. His walking style appears a little bit rigid from trunk and from the neck. His steps are short, half to 1 foot step length, and the cadence is about 85 steps per minute. We can see that he walks with a wide base of support, and the heel-to-heel distance is approximately 15 to 20 centimeters. The functional reach test is about 22 centimeters, and one leg standing is only possible for a short moment, maximal 1 second on each side. What are the underlying impairments? As with the patient from before, cardiovascular, respiratory, and sensory is not an issue. Also, there is no pain. The balance in one leg standing and walking is impaired, but more in a coordinative way. Postural control, the initiation of locomotion pattern, and the precision of movement seems to be a problem. He also has difficulties with speedy movements. The muscle power in the trunk is good, and in the legs the power is fair to good. There is a tone increase, the trunk is rigid, and in both calf muscles there is a catch and release when elongating the muscles in a very fast way. As he does not feel safe when he is walking, especially in open space, insecurity is also an issue. Preparatory exercises will concentrate on the trunk and neck, and here mobility of the trunk and reducing tone is the main target. Dynamic reversal as technique is very useful to gain the necessary range of motion, especially rotation of the trunk.
More exercises for trunk mobilization you can see in the video of Ulla and Fritz about Parkinson patients. With one foot on the stepper, we are challenging here the weight bearing of the right leg. I'm making sure that the base of support is getting narrow, so the feet are closer together. And using the technique of stabilizing reversal challenges the balance situation. The support from the hands is slowly reduced. For more challenge, I'm asking the patient to turn the head to left and right in order to get some additional vestibular disturbances, which will challenge the whole situation for the patient. In the treatment progression, I exchanged the solid stepper to a mobile ball, which will make the situation more difficult for the patient. Throwing and catching a ball in this position will put more challenge on the postural control of the patient and force the patient to work more with adaptations to the disturbances. Practicing cross steps, in PNF we call this braiding, is not only narrowing the base of support, but it's good for practicing protective steps in order to prevent falling, but also very good for getting the width of the feet in gait more narrow. Next, we are practicing the cross steps in a sequence left and right, only in front in respect of forward gait. First facilitated from the pelvis, and the patient is holding on to me. And in the progression, I ask him to take off his hands from my body and try to do the cross steps by himself. I still guide the movement from the pelvis, and we can see this is more difficult for the patient. In the following, I'm asking the patient to walk against my resistance, asking him for taking big steps. So we call this resisted walking in PNF. It's emphasizing the step length of the patient. To incorporate the arm swing and the trunk rotation, I change my contact and ask him to walk, and I facilitate from the shoulders. With patients like him, the auditory stimulation is also very important, so we should accompany our facilitation or the gait with some auditory stimulation, giving him a rhythmical cue. A small weight in each hand, like a wooden club or dumbbell, can be helpful to facilitate the arm swing. The treatment results. Here we see the gait from the side. The step length has increased, so the step length on the right side from 1 foot length to 1.5 foot length, and on the left from 0.5 foot length to 1 foot length. The width has changed. Before it was like 15 to 20 centimeters, now it's a normal base. So here we see the pre-test and the post-test situation with the left and the right step. Functional reach test has improved from 22 to 30 centimeter.
and the one leg standing became better. Nice results. The therapy continues outside the treatment room, so walking on different surfaces, managing obstacles is so important for the patient. Take-home messages. Single limb stance is the most challenging task of the Gait cycle. Gait training needs to be tailored to the impairments and needs of the patient, and that includes hands-on and hands-off applications. And PNF offers a lot of tools to improve the activity of Gait.
So this is the end of my presentation. I hope you liked it and I could give you some inspiration for the treatment of your patients. Tomorrow we will have a presentation about PNF and Parkinson by Ulla Bertischamp and Fritz Westerholt from Switzerland, which is over there somewhere on the other side of the lake. So whenever you treat your patient, remember, use your head, heart, and whenever it's appropriate, your hands. Take care. See you.
Du nie.
Dino.